All right, let's jump right in. Today, we are talking about something absolutely critical in managing bipolar disorder, the reality of long-term maintenance treatment. This isn't just about getting through a tough episode. It's really about building a stable, long-term future. And to get why this is so important, we have to start with one single, very powerful number.
Over 90%. Just let that sink in for a second. That's the probability that someone with bipolar 1 disorder will have a relapse if they stop their treatment. It's a staggering number, right? And it's exactly why having a long-term strategy isn't just a good idea, it is absolutely essential.
So, how do you manage that massive 90% risk? While the approach has to be solid, it has to be comprehensive. We're not talking about just one magic pill, but a whole foundation that's built on 5 distinct pillars of care that all have to work together. And this really gets to the heart of how we think about treatment today. Bipolar disorder is a complex illness. It's got a lot of different facets, so the treatment has to match that complexity. It has to be multidimensional. You can't just treat the biology without also thinking about the psychological and the social pieces of the puzzle. It's all connected. So let's take a look at what those connections are.
And here they are, the 5 pillars. Now, pharmacotherapy, that's the medication, and it's the cornerstone we're going to focus a lot on today. But look at how it's supported by everything else. You've got therapy and education to really understand the illness. You've got social support, crucial lifestyle changes, and self-help strategies. And that's for patients and their families. It's a whole toolkit.
So let's zero in on that first pillar, the medication. When we talk about meds for bipolar disorder, there's one name that has truly stood the test of time. It's the benchmark that pretty much everything else is measured against: lithium.
The story of lithium in psychiatry is pretty fascinating. It kicked off way back in 1949, when John Cade stumbled upon its powerful effects on mania. But the real game changer for long-term care? That came in 1967, when researchers proved it could actually prevent future episodes. Now, fast forward to today, and even with all the newer drugs out there, it's still the first-line recommendation in guidelines all over the world.
So just how effective is it? Well, a major meta-analysis gives us the hard numbers. Compared to a placebo, long-term lithium treatment cuts the risk of a manic relapse by 38%, and a depressive relapse by 28%. Those are really significant numbers that show just how powerful it is as a mood stabilizer. But using it safely requires a whole lot of precision. And here's why that precision is so important. Lithium has what's known as a narrow therapeutic index. Basically, that means the dose that helps you isn't that far off from a dose that can harm you. There's this tiny little window where it's both effective and safe. And that's why constant monitoring is absolutely non-negotiable. So what does that monitoring actually look like? Well, before even starting, a doctor will check key functions. And then, during treatment, regular blood tests for your kidneys, your thyroid, and your calcium levels just become part of the routine. It's all about ensuring safety and catching any potential issues super early. Okay, so let's talk side effects. In the short term, things like being thirsty, maybe a bit of a tremor, or feeling tired are pretty common. But the real reason for all that monitoring we just talked about is to keep an eye on the long-term concerns, specifically the potential impacts on the kidneys and the thyroid. These are risks that can be managed, for sure, but they have to be watched like a hawk. But of course, lithium isn't the perfect fit for everybody. And that's exactly why the toolkit has gotten a lot bigger over the years. So let's take a quick tour of some of the other major players in long-term maintenance treatment. First up is lamotrigine. And it offers a really interesting contrast to lithium. You see, while lithium is an absolute powerhouse against mania, lamotrigine's main strength is in preventing the depressive episodes. And this makes it a super valuable option, especially for people with bipolar 2, where depression is often the biggest, most persistent challenge. Then you've got valproate. Now, it can be effective for treating acute mania, but its role in long-term prevention, well, the evidence is a bit murky. But the real headline here, the thing you absolutely have to know, is that warning at the bottom. It carries a significant risk of causing serious birth defects. This is a massive safety concern, especially for women of childbearing age. And that brings us to a really major trend that's happening in treatment right now. Kind of surprisingly, these newer medications called second-generation antipsychotics, or SGAs, are now prescribed for maintenance more often than the traditional mood stabilizers like lithium. That is a huge shift in how things have been done over the last 20 years. So what's the trade-off here? Well, it really comes down to a different set of risks. With the SGAs, the biggest long-term worry is metabolic. We're talking significant weight gain and a higher risk for type 2 diabetes. With a traditional stabilizer like lithium, like we saw, the risks are more organ-specific, really focused on the kidney and the thyroid.
So what about antidepressants? This is one of the most debated topics out there. They're the go-to for unipolar depression, right? But in bipolar disorder, it's tricky. This quote from the research is crystal clear. For bipolar I, the evidence just isn't there to support using them long-term to prevent depression. Plus, they can even carry the risk of flipping someone into mania.
So, after looking at all these different options, each with its own unique set of pros and cons, benefits and risks, we get to what is really the central challenge of maintenance care. It's a huge balancing act.
And this leads us to the ultimate question, doesn't it? With all this information, with all these options on the table, what's the definitive answer? What is the best treatment?
And the answer is, there isn't one single best. The best treatment is the one that's right for the individual person. You have to ask, is the main goal to prevent mania or depression? What's the person's overall physical health like? What kind of side effects are they most willing and able to manage? It is a deeply personal decision, based on a careful risk-benefit analysis that a patient and their doctor make together.
And that, right there, is really the key takeaway from all of this. The goal isn't about finding one magic bullet that works for everyone. The future of treating bipolar disorder is all about getting better at predicting who will respond best to which treatment. It's a move toward personalized medicine, using all the tools we have to match the right treatment to the right person for the lifelong journey of stability.